Hi, I'm psychiatrist Jay Falver. Welcome to Distance Learning Network and today's activity, Bipolar Spectrum Illness in Primary Care. For more information about upcoming activities, please visit our website at www.dlnetwork.com. In the early 1990s, I had a psychiatric practice that primarily served as a referral base for family physicians, internists, OBGYNs, and other non-psychiatric clinicians. At that time, many primary care physicians were not treating depression. Instead, they chose to refer those patients to me. Over the past 10 years, times have changed. Now, a majority of antidepressant prescriptions are written not by psychiatrists, but by primary care physicians. I believe that this is a good trend. Primary care physicians are becoming more comfortable in assessing and treating depression. By doing so, they provide better access to care and more comprehensive treatment for those patients suffering from mood disturbances. With primary care physicians now doing a commendable job recognizing and treating depression compared to 10 years ago, I believe that it's now time to take the primary care treatment of mood disorders to the next level. That next level would be the assessment and treatment of bipolar disorder in the primary care setting. Over the next hour, my guest expert and I will examine clinical signals that may alert you to the possibility of bipolar disorder. We'll also offer practical suggestions for the treatment of these individuals in the midst of a busy caseload of patients. Joining me to present clinical pearls for the diagnosis and treatment of bipolar disorder in the primary care setting is family physician Sloan Manning. Now, as a psychiatrist, I've admired Sloan's willingness to step up to the plate over the years in recognizing and treating mood disorders in the primary care setting. He works as an associate professor in the Department of Family Medicine and associate professor in the College of Nursing at the University of Tennessee. Sloan, welcome to Distance Learning Network.
Jay, thanks for inviting me.
Sloan, bipolar disorder is also known as manic depressive disorder, and it's part of a mood disturbance that goes along a mood psychotic disorder continuum when we consider prognosis.
It is. Much more of the depressive universe is now recognized as being bipolar. When I was out of residency in 1987, bipolar disorder was considered to be an unusual or a rare diagnosis, but what we've learned over the last 15 or 20 years is that bipolar spectrum disorders, things that are bipolar, classic manic depressive, and related to classic manic depressive illness, much more common in the general population and in primary care than was thought before. And if you just look at some numbers, probably 1 in 4 to 1 in 3 of the depressed and anxious patients presenting in primary care practices would be diagnosable as a bipolar illness if you ask the right questions and applied the criteria properly.
There's a lot of overlap with some of these bipolar conditions, but let's talk about two particular types of bipolar disorder type 1 and bipolar disorder type 2.
Right. Bipolar 1 is the illness that most people in primary care would call classic manic depressive illness. Requires having had a manic episode for diagnosis. Most people will have major depressions as well and actually have depressions predominating over manic episodes. It may be a new concept for people who are in primary care to think of people as being manic and depressed at the same time, but in quite a few percentage of bipolar patients, particularly in bipolar 1 patients, people can meet the full criteria for a manic episode and a major depressive episode at once. And this mixing of manic symptoms and depressive symptoms is something very important for primary care physicians to look for. Not only is it important to look for depression, it's important to look for mania that may not be full-blown but is mixing with the depression that's there. It's a highly familial illness, which means we have to be very careful and begin to be more comfortable asking about family histories of this. Untreated, the suicide rate's very high. When we don't treat this illness, patients will often treat themselves. When they're more agitated, revved up, and manic, they'll often use alcohol to do those kinds of things. When they're more depressed, they may use stimulants or other kinds of things. And the children of people with classic illness typically don't look classic when they get ill. So if your mother, father, sister, or brother has a diagnosis of bipolar disorder and you have a mood problem, you're probably bipolar as well, even though we haven't always thought of that as being the case.
Well, Sloan, you brought with you today some video vignettes with 3 patients for whom you've treated with bipolar disorder. Let's first take a look at Jennifer, who has bipolar disorder type 1.
I'd have to say I first noticed when I was about 16. I went to 8 different high schools. And I knew something was wrong, that I was going to all these different schools, but I never looked into it. So I really didn't find out that I was bipolar, excuse me, until I was 24. 24, and then I didn't understand it, so I didn't do much about it. I was mistreated. I was told that I was clinically depressed and treated with medication for that, which actually made me worse. Instead of getting better, I got worse. My mood swings were higher and lower. To other people, I was a whiz. I was smart. I was on top of things. I could do anything. I felt like I was invincible. That's when I was up high. When I was down low, all of a sudden I'd disappear on my friends, stay in my room, sleep for 13 hours at a time, keep to myself, just become a hermit, basically. And then later that day or the next day, I'd be up on top of the world again.
Sloan, Jennifer nicely conveys the symptoms of bipolar mania, and she also has some pretty significant depression there too, but that's bipolar 1 disorder. Let's take a look at bipolar 2 disorder. Bipolar 2 disorder refers to somebody having hypomania with major depression, and it's so commonly seen in the primary care setting.
True, Jay. Most people come in with this disorder in a depressed phase. Jennifer was talking about her experience. The periods of high energy very often aren't interpreted as being a problem for individuals. Bipolar 2, the most common variety of bipolar disorder that's seen, is defined, as you said, as recurrent hypomania and major depression. But the hypomania is these brief switches into increased energy, typically lasting only 2 or 3 days at a time. It's a female predominant illness, just like in unipolar disorders. The DSM-4 is a relatively poor standard for the diagnosis. Of course, the DSM-4 is about 10 years old now and ready for revision in a couple of years. But these brief switches are not going to be remembered typically by patients as being periods of abnormal energy. They're more likely going to describe it of feeling normal for 2 or 3 days or being energetic for a few days before the depression comes crashing in. And of course, during depressions, the problems with memory and concentration may make it very difficult for people to actually recall that they've ever had these switches into energy if you're seeing them during the depression. So sometimes information from others, significant others, might be very helpful in actually making the diagnosis.
Well, Sloan, let's hear from Connie, who you treated for bipolar type 2 disorder.
I would go from feeling really good, feeling happy, and everything was wonderful, and 2 or 3 days later, I was wanting to commit suicide. As time went on, this pattern got to where it was more of a daily thing. I would go through this several times a day. I would be high, everything was great, everything was wonderful, I had a future, I was going to make money, if my house burnt down, it's okay, I'll get another one, to where I could walk through the house and walk into another room, and I was crying, what's the point in living, I can't go on, and it was just a roller coaster.
Sloan, when you originally treated Connie, I imagine she complained loudly and clearly about the depression, but she may not have emphasized the highs because for her, those little highs were somewhat refreshing from the depression.
Exactly. Those are times when she felt like the depression lifted briefly. And of course, that's what usually happens in bipolar 2 illness. People experience the lows, they have difficulty getting things done, they have depressed mood, all the symptoms of depression that you would think of. And then suddenly they'll switch into a period when they're very active, energetic, maybe on the irritable side for 2 or 3 days, and then suddenly that ends and they're back in the depression. So people rarely complain about energy, and it's important for us to ask about these periods of energetic symptoms and really just feeling normal and find out whether normal comes and goes abruptly, because normal happiness doesn't come and go abruptly.
Okay, our third patient is Mark, and Mark also experienced bipolar 2 disorder.
I tend to have bottoms and lows and really highs and extreme highs to the point of extreme depression, wanting to sleep all the time, no energy, panic attack symptoms, high anxieties, to very productive times of wanting to talk all the time, being creative, moving on a fast scale.
How long are these times of high energy and creativity?
varies. Most of the time it'll go a week or so, sometimes a couple of days, and then I'll crash. I tend to have more of the depression side than the high times.
Do you recall a time in your life that became first noticeable?
Absolutely. When I turned 25, it began with me.
Tell me some more about that.
Was basically at work, had no problems with depression, no mood swings that I can recall, and had a panic attack. I'd never had one before, and it started from there. Basically wound up in the bed for a 6-month period of time. Extreme depression, wanting to sleep all the time, suicidal, just a mess.
Do you recall before the panic attack and then the crash that you were in a period of significant productivity and activity?
Absolutely. Overachiever, owned a lot of rental property, was working on my master's, going all the time.
How much sleep were you requiring when you were going all the time before you crashed?
3 to 4 hours, sometimes 2.
Had that gone on for months and months, or just?
It varied. Sometimes I could do it for 2 or 3 months, and then sometimes it'd only be 2 or 3 weeks. It just depended. My cycle varied, really.
Would you experience this period of energy as abnormal in any way?
I think I came from a long family of manic depressives, so to me it was normal. High energy, people working all the time, overachieving, so I didn't see it at the time as being abnormal.
Did other people experience your periods of high energy as irritating, abnormal? Was there a downside to other people who were with you or working with you?
I'm sure that there were. They never really voiced it to me, but I can imagine it would have been very irritating.
What can you imagine about how that would have struck other people?
I never shut up. I talked constantly, had to be moving constantly. Nothing was good enough. I had to make it better. Never satisfied with my work. No one could do anything right. It always had to be better for me.
But this was almost a way that you had been all your life.
Pretty much.
Sloan, there were a couple of comments that Mark made that I took issue. Number one, he described his hypomania as being a time of productivity. Well, we all want to be productive, so you would think, well, that's normal. And secondly, he said that when he was on these high rolls like this, and he's on the hypomanic episodes that he was describing, that was considered to be somewhat normal based on what he saw within his family.
Sure. The family history showed him, or at least gave him the picture of hypomanic behavior as sort of a normal way of doing things. Now, Mark's hypomania is a little more intense and a little more long in duration than the typical bipolar II experience, but still Mark never had an episode that could be described as a full-blown manic episode, and it worked for him. The energy worked for him for years before he finally had the panic attack that was followed by a very severe crash into a major depression.
When these people with bipolar II disorder have these little spells of hypomania, they will often say, gee, can you just keep me out of the depressions and allow me to have those spells where I'm so productive? Well, it doesn't work that way. If you have the high spells, you tend to cycle more.
And the higher the highs are, the lower the lows are typically going to be after the highs end. You can't stay in the clouds for very long.
Well, Sloan, we've talked about bipolar I disorder, where people have the significant manias, and the bipolar II disorder, where people have hypomania with recurrent major depression. What's the lifetime prevalence in the general population of these conditions?
The lifetime prevalence of bipolar I disorder has always been estimated in various studies at about 1%. Bipolar II disorder, of course, with the more restrictive and probably poorer DSM-IV definition, about 0.5%, and again, females more commonly affected than males. Most of the bipolar patients that you're going to see in practice right now really have diagnoses in what we call the bipolar spectrum disorder, and that's about 5% of the general population. And of course, when the DSM-5 comes out in a couple of years, what we expect with a redefinition of bipolar II disorder is many of the people now defined as in the spectrum of bipolar illness will become officially bipolar II.
The problem that we see with bipolar disorder, not just in primary care practices, but also in psychiatry, is that these people are often misdiagnosed and inadvertently treated with antidepressant medications. As a psychiatrist, I have done that on several occasions. I thought I was treating somebody with major depression and unipolar depression, but lo and behold, I later find out that they're having hypomanic episodes.
The diagnosis can be very challenging to make, particularly since patients will sometimes underdescribe or hide their symptoms or not really be aware that these energetic symptoms might be important. The National Depressive and Manic Depressive Association has twice in the last 10 years surveyed its bipolar membership and asked them the question, how long did it take you to actually be correctly diagnosed as bipolar in a psychiatrist's office? And what this particular survey revealed is that a lot of different psychiatrists had to be consulted, a lot of misdiagnoses, a lot of people suffering for a long period of time before the correct diagnosis was made. And of course, it's only after you make the correct diagnosis that the treatment becomes more one of mood stabilization and less of using antidepressants, because many of the people in this particular survey had been treated repetitively with antidepressants, and the antidepressants had not only not worked, some of the people had gotten significantly worse because of being exposed to antidepressants as monotherapies for the depressions that they presented with.
Sloan, let's return to the videotape of Jennifer, where she describes the consequences of misdiagnosis and antidepressant treatment for her.
Was it only during the depressions that you sought help, or did you seek help when your mood was in the high state?
It was definitely during the depression, because that's when I started realizing, hey, something's not right, something's wrong. When I'm manic, hypermanic, everything's coming up roses, everything's fine, you know. But when I was down, I was down. I hit bottom, and that's when I'd finally go for help. But you know, I didn't know what was wrong with me. So whatever the doctor told me then is what I had to go by. You know, you're clinically depressed. Okay, here's your prescription. Okay, you know. But it was definitely when I was depressed that I would go.
So Jennifer is an individual who was being treated for depression, initially was placed on various antidepressant medications, and inadvertently was probably exacerbating her rapid cycling by taking the antidepressant medications.
Jennifer had a couple of occasions with treatment-emergent hypomania and mania, and you're exactly right. The more antidepressants she was given, the higher the highs, the lower the lows, and the more there was a tendency to mix the highs and lows together to create a mixed state we'll talk about in a few minutes, and also to shorten her cycle length. She would spend less time high and, you know, less time low, and it became a real problem because the depressions became more mixed, aggravated, agitated, and more dysfunctional because of the failure to recognize that she actually had a bipolar depression.
Sloan, many primary care physicians have told me, well, gee, primary care doctors don't see bipolar disorder in their practices. And actually, that's not true.
It's not true. It used to be thought of as being true, but again, the studies of depressive subtypes in primary care 10, 15 years ago didn't ask questions about bipolar disorder. We do most of the treating of depression in the primary care spectrum. So if you just looked at the newer information on prevalence data, 5% of the general population, and then realized that primary care was doing most of the treatment, you would at least have some indirect evidence of a high prevalence of bipolar disorder in the primary care field. But there are newer studies, direct studies, using more sensitive instruments in primary care that have shown, again, that about 1/4 to 1/3 of the depressed presentations in primary care actually are bipolar disorders.
Now, we psychiatrists see a good number of people with bipolar disorder, but many of them are in the primary care settings, and you've done a very nice job actually studying this in your family practice setting.
We've done a couple of studies. One is a consecutive patient waiting room study where we just took people as they came, screened them all for anxiety and depression, and then applied a diagnostic instrument that was sensitive for bipolar kinds of issues. And in this study, we found bipolar 2, again, the most common variety of bipolar disorder, not uncommon at all. There were some people with classic illness, but only about 3% of the population, and there were a few people that I didn't even recognize when they came in, as you were talking about. When I put them on antidepressants, the antidepressant revealed the fact that they were bipolar, and so it's a challenging diagnosis. Later, when I got to the University of Tennessee and we set up mood disorder clinics in our residency programs to actually look at this phenomenon and teach people about the phenomenon, we again saw that a very high percentage of refractory patients presenting in our on-site consultation clinics had a bipolar spectrum diagnosis if you ask the right questions, put treatment response, family history, and longitudinal course all together. And it's really kind of interesting that the 39% figure you see there in this population of patients that would otherwise have gone to a psychiatrist, this is the percentage of bipolarity that's showing up in outpatient psychiatric studies as well. So it correlates very well with what's happening in your specialty.
Well, what kind of diagnostic pearls can we convey to primary care physicians as well as psychiatrists in trying to pick up some of these people with bipolar disorder?
Yeah. Well, we often miss elements of the diagnosis and diagnostic history. People are not very accustomed, don't really know that it's very important to look at family histories. Unipolar family histories tend to be sparse or maybe even negative. If you ask somebody with unipolar illness, does this run in your family? They may not be able to find anybody or maybe one person. If you ask somebody with a bipolar disorder, does this kind of illness run in your family? They'll say, boy, let me tell you about my family. And what you get is a loading effect where 3 consecutive generations will have evidence of an impairing mood disorder, or 3 or more people in one generation will have evidence of an impairing mood disorder. This other aspect of antidepressants making people worse, introducing agitation, restlessness, racing thoughts and insomnia, or people getting briefly better and maybe even suddenly better on antidepressants only to crash after a few weeks after the antidepressant starts working. Things that I have called before antidepressant misadventures. Right now, one of the best ways to recognize bipolar disorder in a primary care office is to look for anybody who's been on 3 or 4 antidepressants and you can't find the right antidepressant for the patient, or one works and one doesn't, the next one causes depression to be worse or agitation to be worse, those kinds of things. Bipolar women are at particular risk of having postpartum mood disruptions, and that's not to say that all postpartum depression is bipolar, but they're so sensitive that it's important to rule out bipolar disorder in any woman coming in with a postpartum mood disorder, particularly if the postpartum depression is their very first major depression. Of course, we now recognize postpartum psychosis, thankfully rare but very disruptive and very dangerous disruption of mood postpartum to be mainly bipolar. The early age of onset, again, if you ask somebody who's unipolar, how old were you when you had your first significant episode of depression? They'll say 25, 30, 35 years of age. The average age for people getting into antidepressant studies for unipolar illness is about 41 or 42, and it's predominantly women. When you have people telling you that they had their first depression as a child or an adolescent, and those depressions are multiple, lots of them, severe, maybe even psychotic depression as an adolescent, when the moody storms begin in childhood and adolescence and get worse over time, that's a strong indication, because of the early age of onset, that you're not dealing with a unipolar and therefore antidepressant monotherapy responsive illness.
Well, Sloan, let's take a look at some video examples of the loaded family history. Connie and Mark describe their family histories, and you'll notice that they don't talk about manic depressive disorder or bipolar disorder. They talk about alcohol dependence, psychotic illnesses, anxiety disorders. Let's take a look.
But my sister had always had these problems, even since she was a little girl.
Tell me more about her.
As far as being a little girl and growing up, the only thing I can remember is my mother always say she's different. She's different, she's different. As she got older and got to become a teenager, she started drinking. As she got into her 20s, the depression started hitting her, and she's been in and out of mental institutions. She's been diagnosed as being schizophrenic, psychotic. She talks to herself. She can hear people talking to her. And this comes and goes. This is not an everyday thing. She takes these by, it might be 1-2 years before these episodes come on her. She gets into really deep, deep depression. She has tried to commit suicide 2 or 3 times.
Well, I feel like it's really on both my mom and my dad's side of the family. I think that alcoholism runs hand in hand with it. My mom had a severe track of alcoholism in her family with her brothers. Her grandmother was a depressed person. My mother is obsessive compulsive, obviously, and I think suffers from depression. I have a niece and a nephew that are bipolar as well. One of my sisters suffers from depression. I have an aunt that is also suffering from depression. On my mom's side, my dad's side, it's basically the same thing. It's a high level of alcoholism on some of his aunts and uncles, and a lot of depression.
So we hear about the depression, the psychotic illnesses with Connie and Mark and their family histories. Let's take a look at how Jennifer conveys her antidepressant misadventures by being placed on an antidepressant alone in the face of bipolar illness.
I was given Paxil, and I was given Zoloft. And it actually seemed when I was taking those pills, I was more hyper than usual. I would go off, just do my own thing, just up and leave and go to the casinos in Tunica, just, take a whole paycheck and blow it and not even care, which I didn't have that money to spend. But in my mind, I was invincible. I could go out there, I can do it.
Do you recall that your thoughts were racing or uncontrollable?
Yes.
Tell me about that.
I used to pray that God would just let my mind be quiet for a while, just for a little bit, just a little bit of peace, because my mind, with things I've done or things, memories or things that might happen, they all race through my head all the time. And it's terrible. Can't sleep because my mind won't shut down.
Body fatigued and mind keeping you up at night?
Yes, correct. My body wanted to sleep, but my mind wouldn't let it.
What's the longest period of time you ever went without sleep?
4 days. And I'm not even a nap or anything, just going.
It doesn't surprise me that people thought you were doing cocaine or crystal or stuff like that, because that's what people, sometimes that can cause that kind of thing.
Yeah, I think that's probably why they put me in rehab, because I was out of control and they didn't know why.
Many people with bipolar disorder are in chemical dependency rehab. It's interesting in Jennifer's case that she describes this antidepressant misadventure, and so commonly, if you place a patient on an antidepressant medication, you think they're depressed and you see them go off like Jennifer describes, that's a tip-off they're actually bipolar.
Anytime antidepressants work suddenly, like a flash in the pan within the first 2 weeks of using it, the idea that people come in a completely different mood after only 1 week or 10 days on an antidepressant. Antidepressants normally take 1 or 2 weeks just to get started and 6 or 8 weeks to have their full effect. So when you get this sort of miraculous cure on an antidepressant in the first couple of weeks they're on it, that's a bad sign typically. And Jennifer talked about how the antidepressant really introduced more manic symptoms. The antidepressant made it more difficult for her to sleep, caused more restlessness, more agitation, and more behaviors that got her into difficulty with spending money and things like that.
So that is a tip-off.
That's a
Giving the
tip-off.
antidepressant medication and they feel much worse.
Or much too much better, much too soon.
Well, let's talk about the overall symptoms of hypomania and mania to review, because primary care physicians have been very well versed on the diagnosis of depression. Let's talk about the other end of the spectrum.
Sure. And we have a new mnemonic that we'll get to in a second called Dig Fast, but most of us know what the symptoms of depression are. The symptoms of mania are less familiar because they've been less emphasized in primary care education. Though, if we remember correctly, can remember inflated self-esteem or grandiosity. And again, this doesn't have to be delusional grandiosity. It just can be a substantially different level of self-esteem and recognition of one's potential, if you will, for the future in themselves than their usual depressed kind of self-esteem. There is a decreased need for sleep, but it may only be going from 9 hours or 10 hours a day down to 5 or 6. There doesn't have to be a dramatic shortened sleep. There is a tendency for people to be more social, more talkative, maybe even to talk so rapidly that they're difficult to understand because their thoughts are racing and their subjects for their conversations are switching a lot. They do get a lot of things done, but not necessarily a lot of things in quality because their minds are moving so quickly that their activities are changing rapidly. They may have 4 or 5 things going at one time, and that may give the manic or hypomanic episode this appearance of productivity and well-being. But the fact that they come and go abruptly means that people are making decisions during these periods of energy that are not based on a good assessment of reality. They're just sort of being very impulsive spending $200 or $300 buying things, and then 2 days later you've totally lost interest in the project you thought you were buying it for. Things like financial indiscretions, going too far romantically, fast or reckless driving, lots of those kinds of impulsive activities can have negative consequences during this period of energy, but somewhat lack of judgment.
And the difference between hypomania and mania will be the severity and duration of illness. But the point is, in either case, you do not want to place these people on an antidepressant alone, even though they seem to be depressed at the time.
That's exactly right. You may drive the person with only hypomanias into a full-blown manic episode, or you'll mix the depression with agitation, restlessness, and other manic symptoms that will eventually and actually make the depressed episode much more difficult to treat.
Okay, well, Sloan, we've heard about the Siggy Cap and the Sad Faces mnemonic for depression. Let's take a look at the Dig Fast mnemonic for hypomania or mania.
The Dig Fast is just another mnemonic that's been recently developed just to, again, to remind people of what manic symptoms are, because an important task in any evaluation of a depressed and anxious patient is actually asking whether these manic symptoms are present, particularly at episodes. And again, D is for distractibility. There's the I for insomnia, the decreased need for sleep, the grandiosity or inflated self-esteem. The idea that people get a sense that their mind is moving too fast for their body, their thoughts are crowded, they can't get one thought completed before thinking of something else. They are certainly more active, sometimes more active and more irritable at the same time, but the speech tends to be more talkative, more pressured, more social. Actually, in depressed states, people tend to be a little socially anxious. And again, the T in Dig Fast is for behaviors that are thoughtless, risk-taking behaviors that center around sexual indiscretions, financial indiscretions, traveling impulsively, driving recklessly, those kinds of things.
Well, let's review 5 key factors for the diagnosis of bipolar disorder.
This is very important because these are 5 factors that would differentiate bipolar spectrum illness from unipolar spectrum illness. And again, a couple of things we've already talked about, just starting at the top of the star, the age of onset. Illnesses that begin early, childhood or adolescence, with high episode rates and more severe manifestations tend to be more bipolar than unipolar. When the illness is coming out of a family history that is loaded in consecutive generations, or when 3 or more people in a single generation have clear evidence of a mood disorder, that's more likely to be bipolar. As one person I heard once described it, these people are in trouble before they're actually born because the genetics is so high. These people do have symptoms of hypomania and mania, but not severe enough and long-lasting enough to be described as classically manic depressive, but you'll see people with depressions who are energized, people who are depressed and on the go, depressed and mood changing rapidly or unexpectedly from high energy to low energy. And then there is the course of symptoms. Typically for a unipolar major depression, people are spending 6 to 9 months in sort of a gentle sloping prodrome where they get sort of slowly sick into a major depression. People with bipolar depressions can wake up in a severe depression, just a sudden switch kind of thing. The bipolar depressions and symptoms tend to be seasonal very often, with winter times usually more predominating with depressive symptoms, and summer times maybe more manic or energized. And again, response to treatment, which is not even included as an official way to look for the illness in DSM-4, but we expect will be in DSM-5, the idea of antidepressants not working well, not working correctly, improving energy and mood, but introducing insomnia, racing thoughts, or the idea that people are just on 3 or 4 or 5 antidepressants and nothing seems to work very well for very long, and the bipolar depressions tend to be a moving target for antidepressant monotherapies.
Well, Sloan, over the past 10 years, primary care physicians have been able to recognize depression by using simple self-administered scales like the Beck Depression Inventory or the Zung Depression Test. What kind of test do we have for bipolar disorder that you can give to a patient and have them fill it out?
There's a screener that's been introduced in the last couple of years that's called the Mood Disorder Questionnaire, or MDQ. It's a brief patient self-report summary where patients actually are asked about 13 different manic symptoms during the first question, where they respond yes or no. The second question is one in which they're asked whether these manic symptoms occur together. In the third question, they're asked about the level of problems that these manic symptom periods cause. And if you check off 7 or more manic symptoms that happen concurrently and are causing at least a moderate level of impairment, the MDQ screen becomes positive 70% of the time, meaning a 70% sensitivity and a 90% specificity with bipolar 1, 2, or NOS, with the SCID, or Structured Clinical Interview for the DSM-4, being the gold standard there. And again, the screeners are never going to make a diagnosis for you, but they're going to suggest people who need closer examinations in terms of histories and family histories and things. In my practice, I use the MDQ probably more to begin to ask the questions about manic symptoms. And if they only have 2 or 3 that are positive, I want to know what the patient means, because sometimes patients will underreport their symptoms, and it's been helpful with me as well to give, for instance, a husband and wife the MDQ together, or a significant other and the patient the MDQ. And sometimes the differences are conversation points that we can use to get at the actual diagnosis.
And the point is 7 out of 13 yes responses on the MDQ can tip you off to maybe that person being bipolar.
Exactly.
Often when I've missed bipolar disorder, I thought I was treating an agitated depression, and many times that turned out to be a bipolar mixed state.
Yeah. Again, the idea that you can be manic and depressed at the same time in certain sort of mixings is very important. When we talk about a full-blown bipolar mixed state, we talk about periods where there is an angry restlessness, very severely agitated, that people are often getting prescribed benzodiazepine compounds or maybe asking. But this is not going to respond typically to a 0.5 milligram of lorazepam or alprazolam, twice a day. These people are requesting 2 milligrams of alprazolam or 2 milligrams to 4 milligrams of Klonopin several times a day. And these are people we formerly may have considered to be agitated depressions and things like that. But when you create a mixed state, this period of energized depression, either you can detect it before you start treatment, or if the treatment with antidepressants sort of creates or moves people into these mixed states, that is a clear indication that they are in the bipolar spectrum and that the antidepressant is making matters worse rather than better.
Sloan, before we talk about treatment, let's review some hints of bipolarity for patients who we see in our practices.
And first of all, we want to just re-emphasize the need to shake the family tree. I mean, we talk about the apple never falling very far from the tree. It's very important in any of these individuals to find out where the genetics are in the family to the greatest extent possible. Sometimes you can actually see this illness in milder manifestations in the temperaments or personalities of those people, meaning people with small mood swings often over time get larger mood swings. People with small amounts of hypomanic or manic symptoms over time may get full-blown episodes. These people are often artistically creative, very intelligent individuals, but you're looking at a more positive family history, an earlier onset illness, one with a higher level of recurrence, a higher level of severity, seasonality, and particularly for the bipolar 2s, this concept of mood lability, the idea of I never know where my mood's going to be from one day to the next. My mood's either high or low, rarely in between, or nobody knows what mood I'm going to be in anytime they see me. That's very characteristic of the bipolar 2 presentation and a lack of responsiveness to antidepressants.
And as you had mentioned, there are some biological vulnerabilities from a medication standpoint.
This is true. We've talked about the antidepressant vulnerabilities where you can make matters worse with antidepressants, but you can also make matters worse with corticosteroid treatments, and many of us have had the experience of seeing manic symptoms emerge out of a prednisone taper. Bipolar women are often intolerant to having the reproductive hormones messed with, and they may be the ones who get very moody or even frankly depressed on birth or oral hormone replacements or birth control pills. It's the progestins that seem to be the most offensive there. The sleep deprivation going on short nights can often reproduce manic symptoms. And again, the rapid, exaggerated, or unexpected antidepressant responses, too good to be soon, too true to be soon, flash in the pan, agitating, anxiety-provoking, or the idea that the more I treat with antidepressants, the more refractory they become. Sometimes in bipolar depression, the first antidepressant you use may have a fairly normal and good response, but when they go off the antidepressant in another episode of depression, you put them back on the same antidepressant that worked well before, the antidepressant doesn't work the second time. And again, the bipolar depressions tend to be a moving target. The biology seems to somehow change over time, and antidepressants may actually move the biology into places that are more difficult to treat.
Well, let's once again hear from Connie, who describes very nicely the social impact of her bipolar condition.
if I can avoid people at all costs, I will. I mean, I will stay in my house for days, not go out. I won't go out into my yard if my neighbors are outside. I will go from the front to the back to see if their cars are there. If their cars are gone, I'll kind of tend to go outside and, you know, maybe work in a yard. As far as going to stores, I'm so afraid I'm going to see people that I know. I'm not so scared to go out if I'm with somebody that I feel safe with. For instance, say my children, maybe my father. When I come to your office, I feel safe. It's just where I come from, they're called hermits. I've become a hermit.
What's the fear?
Of losing control, of being in a situation that upsets me, that of just not having control over a situation.
Sloan Connie sounds like somebody who has social anxiety disorder to me.
It's very difficult for some people to think of people who are bipolar as being socially anxious, because we think of the hypomania to mania and the life of the party sort of active, talkative part. But people with bipolar disorder spend most of their time in depressed episodes, at least particularly so in bipolar 2. And the bipolar 2 depressions particularly tend to be very socially anxious, low-energy depressions. And as a matter of fact, in some of the recent comorbidity data that's been collected, if you have social anxiety symptoms and depression, you're twice as likely to actually have a bipolar depression as you are a unipolar depression. So some of these bipolar patients have come in with magazine articles or seeing TV advertisements for social anxiety disorder treatments and have requested antidepressants when they really don't need antidepressants. They need treatment for their bipolar disorder.
So the point is, if somebody describes social anxiety disorder to you, don't reach for that SSRI too quickly.
Not right offhand. You want to do your work and do the job and differentiate bipolar from unipolar disorder.